Yeah, thank you.
Wonderful presentation.
Thank you, sir. Thank you very much.
Thank you. I call upon next speaker, sir. Dr. Vijaya Saradhi on spinal tumors, tumors of the spine. Hello, Vijay Saradhi garu.
He's there already sharing his screen, Babji.
Okay, thank you.
Yeah, can you hear me, sir? Hello?
Yes, yes, yes. We
Yeah,
are able to
yeah,
hear and see you also. Welcome,
yeah,
Dr.
yeah.
Vijay.
Thank you, sir. Thank you, respected chairpersons, distinguished delegates. I sincerely thank the organizers, Dr. Venkat Rajgaru and Ravi, for inviting me to give this lecture. And also, when Varaprasad asked me to talk on some topic, I asked who are the persons along with me. They said that he named Dr. Krishna, who is my senior, who was Jain, and also Narsingh Rao, who is another Jain, who is my junior. So I still remember how we had a very good time in Nizams. So we all are from Nizams, and I still remember Dr. Narsingh Rao, when he tried to join NIMS in neurosurgery, he came and asked me one question, sir, should I join neurosurgery or should I go to surgical oncology? So that was almost, I think, 20 years ago, but he has become a wonderful professor in hands. And so my topic, after seeing Dr. Ramakrishna showing so many videos, horror videos, I'll just make my topic very simple. I'll be talking on the tumors of the spine, which the very interesting tumors. So the goals of my talk would be make the residents or consultants familiar, to make them familiar with the nomenclature of the tumors and how to identify the tumor so that we can deal logically, and treatment strategies, of course, and decision making, which is very, very, very important in malignant tumors. Of course, I don't really touch upon the radiotherapy, chemotherapy part because they're all in the purview of radiotherapists as well as the chemotherapists. So, why these tumors have to be dealt by the neurosurgeon? For the simple fact that these patients present to the neurologist or a neurosurgeon with neurological symptoms, and most often they are mistaken for others. They are mistaken for intradural tumors, they are mistaken for the other diseases. And very fact that they are close proximity to the neural structures, it is pertinent on our part to deal with these lesions rather than giving them to a orthopedic surgeon. Of course, for a resident, it's very important to know this to talk in the final year examination. Invariably, these questions are asked in the final year viva or in a spinal case when it comes to them. So when you divide the vertebral body into anterior half and posterior half, most of the malignant tumors, they occur in the anterior half, and most of the benign tumors will originate in the posterior half. Of course, there are certain benign tumors like hemangioma, eosinophilic granuloma, and GCT do take origin in the anterior half. And some of the malignant tumors like osteosarcoma, chondrosarcoma, sometimes they can take origin in the posterior half. So when you look at the MRI, sometimes if you see all multiple lesions in the spine, you tend to think that we are dealing with the malignant lesions. But all multiple lesions, are they really malignant? No. There are certain benign lesions like exostosis or hemangiomata or eosinophilic granuloma. So all these benign lesions can also be multiple, contrary, unlike the like metastasis, myeloma, or lymphoma. So how do these spine tumors present to the clinician? One, there won't be any symptoms in the asymptomatic phase, or they can present with the axial pain. As long as the tumor is within the confines of the body, as long as it doesn't touch the periosteum, they will be asymptomatic. That moment the tumor grows big enough to stretch the periosteum, it will give rise to axial pain. Suppose if it comes out of the body and reaches the neural foramina, it can give rise to radicular pain And once it comes out of the confines of the posterior cortex, it gives rise to myelopathy. So let me just talk on the primary benign tumors of the spine. First and foremost is that, let me present in a case by case basis. He is a 50-year-old male patient presented with a spinal pain, which was worse at the night, and he was referred to psychiatrist. On examination, he had a scoliosis to the right, and he has no neurological deficits. And one of the orthopedic surgeon who advised a scoliosis correction for this person. So when you take an X-ray, you can see it looks like scoliosis. There's a pedicle end on view. You can just see a dot here. There's something wrong here. This pedicle is all right. There's some dot here. When you do an MRI, it looks very hazy, edema, T2 weighted images going this way and that way. And we cannot really make out any lesion here. And when you do a F18 bone scan, which is nothing but poor man's PET scan, you can see a lesion here, which is a sclerotic lesion. This is nothing but a osteoid osteoma. So let me remind you that it was in 50 years ago, this paper was published from Osmania Medical College by none other than our Professor Raja Reddy and Dr. Dayananda Rao. He was a medical student. Just for the sake of residents, how the young clinician with enthusiastic clinician could make out this. So they described in their paper this pain as a continuous pain, boring in character, worse at night. At first, analgesics could relieve the pain, but later relief was only partial. The pain had to be so severe, the patient became intensely irritable and aggressive. In consequence, he attended to the psychiatric department. This is how patients are they present even osteoid osteoma. Is there initially all right, over a period of time their pain was so aggressive that they will be referred to psychiatrist. In fact, this patient even was referred to a psychiatrist, and where electroconvulsive therapy was also given. This was published almost 50 years ago by our teacher. Coming to case number 2, she is a 24-year-old female presenting with a neck pain and quadriparesis of 1 month duration. On examination, she has grade 4 spastic quadriparesis. So probably there's a lesion in the cervical spine, a extradural lesion. Let us see what it is. In the CT scan, we can see that there is a faint outline of C2. So entire C2 is eaten away by the lesion, and you can see the cranial settling. C1, C3 are coming together. When you look at the CT scan, the entire C2 is hollowed out. This is something like a I think in the childhood we have read about ghost in the Chandamama stories. This is how it looks. So the beauty of osteoblastoma is the cortical borders will be intact. So if you want to excise the lesion, you have to break the cortex to scoop the lesion. What are the differences between the osteoblastoma and osteoid osteoma? Of course, the treatment of choice is a total resection of the osteoblastoma. About 1/10 of these tumors will recur. Then we wanted to find out which of the tumors are likely to recur in osteoblastoma. Literature says that osteoblastoma, once you excise that, there's no need for any radiotherapy, but there are 10% of the patients who are likely to have recurrence. So we had conducted a study in our department. We gathered around 18 cases of retrospective study. When we analyzed the results, there are the variant of osteoblastoma with epithelioid cells, which predicts its aggressiveness, and those patients with epithelioid cells in the osteoblastoma, they need closer follow-up and radiotherapy, probably if it is incomplete excision. So what difference between the osteoid osteoma and osteoblastoma? Osteoid osteoma is like less than 2 centimeters. They have night pain, but osteoblastoma are more than 2 centimeters, no pain. There's no sclerotic rim. Always the osteoblastomas can give rise to neurological deficit because they grow more than 2 centimeters. There won't be any recurrences in the osteoid osteoma, whereas osteoblastomas, they recur if they have epithelioid cells. So this so on and so forth. The other, if you look at this is another case of osteosarcoma. When you look at all the three entities, osteoid osteoma, conventional osteoblastoma, aggressive osteoblastoma, that is with the epithelial cells. And the fourth one is the osteosarcoma, where is a sclerotic variety. All these four are the part of the same continuum of the lesion: osteoid osteoma, osteoblastoma, aggressive osteoblastoma and osteosarcoma. So third case is there is a 15-year-old male patient who presented with the acute onset of quadriparesis following a trivial trauma. That indicates there is a stenosis in the cervical spine. So on examination, it was very bad, grade 2 quadriparesis. So when you look at the CT scan, you can see this lesion which is coming out from the posterior elements into the canal. This is like a mushroom shape. This is a cartilaginous cap. You can see it in the coronal section, axial section. How beautifully you can see this lesion. This is nothing but a case of osteochondroma, and the treatment of choice is total lesion along with the cartilaginous cap. That will cure the lesion. So this patient had made a recovery over a period of time because he presented with acute neurological deterioration following a trivial trauma. Case number 4, she is a 25-year-old female presenting with a backache and weakness of the feet. On examination, features are suggestive of cauda equina syndrome, bowel and bladder are intact. 2 lesion with a MRI shows hypointense lesion with a soft tissue. Looks something a lesion which is arising from the bone. When you contrast, you can see that there's 2 bumps here, probably indicating this lesion is very, very vascular. So probably we can think of metastasis from the renal cell carcinoma or thyroid. When you got an angiogram, then there's a tumor blush. So these things are very important in treating these patients while selecting the patients for surgery. So next choice of investigation is a CT scan. In the CT scan, same lesion looks a polka dot sign. So if polka dot sign is present in the CT scan, never ever attempt to operate the case without devascularizing the tumor. So what are the various treatment options for the hemangiomas? If the hemangioma is asymptomatic, the patient is asymptomatic, don't treat the patient. If the patient has painful hemangioma, 2 options are there. One is a local radiotherapy, or you can have a augmentative therapies like vertebroplasty or kyphoplasty if pain is so severe. And if the patient has a deficit with hemangioma, you have to decompress the lesion. And before decompressing, you have to embolize the lesion. Angioembolization is a mandatory, or you can inject the alcohol or a kyphoplasty and excision or fixation. If the patient has posterior cortex of the vertebral body is intact, as well, we can do a kyphoplasty. Whereas if the posterior cortex is breached, putting a cement is sometimes it is a risky. So another case is a 12-year-old girl presented with the complaints of mid-dorsal pain followed by swaying while walking. On examination, posterior column signs are present that indicates the patient has some lesion from the posterior element which is pressing on the spine. You can look at this. Look at this. There is some the lobulated lesion, very lesion from the posterior elements going into the body. And in the closer look, sorry, I did not the image. Patient this image had some fluid levels, blood fluid levels. So what is a radiological clue for these aneurysmal bones is if you have a missing spine, like if you take an x-ray, if the spine is missing, probably you are dealing with a case of a aneurysmal bones. As a neurosurgeons, we become scared to look at the term like aneurysm, but usually they are not vascular. The moment you break open the lesion, you can just scoop the lesion very well. And if it is a vascular, most probably the lesion could be telangiectatic osteosarcoma or Jane's tumor. Usually these lesions are lined by endothelium. There are not much vessels associated with the lesion. So another case is a 40-year-old female patient presenting with a backache and bowel bladder involvement. And patient has a lower limb patchy hyposthesia and bowel bladder deficits. Probably there is a cauda equina. Look at this lesion. This looks like it's something like osteoblastoma. It has eroded the entire vertebral body and looks like little benign aneurysmal bone cyst or osteoblastoma. But look at the clue. This is eroding the adjoining facet joint. So looks some clue that probably lesion is little more aggressive than the benign lesion. So maybe we are dealing with a lesion which is more aggressive. Like this is the case of a Jane cell tumor. You can see the lesion has entered the vertebral body and also it is reaching the posterior elements through the pedicle and also indenting the cord. So generally, the treatment of usually they are locally malignant. The recurrence are more often seen in the gene cell tumors as any other part of the body. So sometimes you may have to do preoperative embolization if you suspect that the lesion is more vascular. So generally now that after the advent of denosumab and once we decompose the lesion, scoop out the lesion thoroughly and reach the margins, denosumab it has a promise in treating these patients in the post-operative period when in avoiding the recurrences. So as a neurosurgeon, we have to decompose the lesion, and if it's producing the instability, the fixation is the rule, the general rule. So sometimes now people are coming up with newer therapies like interferon as a salvage therapy in the recurrent cases and residual cases where the en bloc excision is not possible because of their location. So coming to the primary malignant tumors, so we have the osteosarcoma. This is the only sarcoma which is arising from the posterior elements. So usually it has a lytic variety or a sclerotic variety. Sometimes these lesions can be seen as a ivory vertebra. And clue to the diagnosis is a Paget's disease. If a patient has Paget's disease or a patient has a history of radiation taken before, probably if you have a lesion in them, probably it could be a osteosarcoma. So osteosarcoma generally treatment is excision, and usually the prognosis is very poor in these patients. So another case is a 12-year-old patient presenting with the paraparesis and with swelling over the dorsal region. So on examination, she had a grade 3 power, and we had clinically a patient dorsal paraparesis fee, we thought probably it's a tuberculosis. So when this is what is lesion, a lesion which is just arising from the vertebral body, the huge soft tissue. So huge soft tissue, you can even palpate the soft tissue from the skin. This is what exactly mimics the tuberculosis. This is nothing but the Ewing sarcoma. So the clinical radiological clue for Ewing sarcoma is the, the age of presentation is less than 20, and you have a huge soft tissue compared to the bone. The bone destruction is, the soft tissue is out of proportion to the bone destruction. The treatment of choice is you have to excise them totally as far as possible, and subjecting them for the radiotherapy or chemotherapy. Clinically, how do you distinguish them? Ewing sarcoma, generally, they are more prevalent in the lower spine compared to upper spine, usually sacrum and all these things. And we don't find typical moth-eaten appearance in the spine as we see them in the appendicular skeleton. And the clinical clue, as I said, the soft tissue is overwhelming soft tissue, gives you a clue that probably this is a Ewing sarcoma with raised ESR. So if patient has raised ESR, constitutional symptoms, large, huge soft tissue with a younger age, so probably a Ewing sarcoma has to be kept in mind along with the initial diagnosis of tuberculosis. So generally, these patients are initially mistaken for tuberculosis. So most effective is this is the only tumor which responds well to the chemotherapy, and as a surgeon we are supposed to debulk the tumor as much as possible and subject them for the chemotherapy. So unfortunately, the 5-year survival rate is less than 20% for patients with this malignant disease, in spite of so-called trimodal therapy, surgery, radiotherapy, and chemotherapy. So this is another case of non-sacral Ewing sarcoma where you have a huge soft tissue here, vertebral bodies. Here the vertebral body destruction is less, whereas the soft tissue is more. So chondrosarcoma is another malignant tumor of the spine where more often there you see them in the thoracic location because of the simple fact that thoracic vertebrae or thoracic location has more cartilage than elsewhere, and usually they are very lobulated. You can see here the lobulations. You can have elements of bone, elements of cartilage, and elements of necrosis. If these three elements are there in the dorsal location, that too in a young male or female, probably this looks like a chondrosarcomas. Chondrosarcomas are very slow growing tumors, but always they are detected very, very late. That's the reason that wide excision, sometimes it may not be possible. If feasible, wide excision of the lesion is the treatment of choice. Generally, radiotherapy or chemotherapy do not act upon these chondrosarcomas. So next is another case is A 56-year-old female presented the low backache and claudication. On examination, there were no deficits. Probably the consultant thought that he's dealing with a case of degenerative disc disease. This is what a disc here, L4-5 disc. Patient initially planned for discectomy, thinking that this is the cause. On MRI, you can see that the sacrum shows some amount of lysis here with the soft tissue. You can see T1, and on the CT scan, you have this sort of bony destruction in the sacrum. This is nothing but the chordoma, which arises from the notochord. Usually, chordomas are generally they take their occurrence in the sacrum. In the elderly patients, usually they are mistaken for the degenerative disc disease. So while looking at the MRI, always you have to look at the sacrum. How are the signals at the sacrum? Is there any soft tissue in the sacrum? Are we missing out any lesion? So usually chordomas, you are missed in this way. Another case is 55-year-old male presented with the constitutional symptoms and paraparesis. Probably, I feel it's a tuberculosis. And other close mimic of tuberculosis, apart from Ewing sarcoma, is a lymphoma of the spine. Lymphoma of spine. How do lymphomas reach the spinal canal? That lymphoma of spine can it can reach the spine through the intervertebral foramina, or extradural lymphatics. They themselves can give rise to lymphomatic deposits. So how does it look in the X-ray? In X-ray, it looks as if a cotton is stuffed into the vertebral body. Sometimes CT may be normal. So if this is ivory type of vertebra is there, patient has a constitutional symptom. Of course, if the patient has a known case of lymphoma, anyway, the diagnosis written on the face of the patient, and there is a strong male preponderance in the lymphoma of the spine, almost similar to that of meningiomas of the female, almost 8:1 strong male preponderance of a lymphoma of the spine. So generally radiological clue, usually the spine and transverse process with a reasonably good spine without destruction, with a large soft tissue mass, you should think of a lymphoma. Look at this. The paucity of radiological destruction with the disproportionate soft tissue is something like Ewing's, is another clue for the diagnosis of lymphoma. And generally, the lymphoma is a medical disease, but there are certain surgical indications where patients deteriorates rapidly, or if there is a diagnosis in doubt, whether you are doubtful whether it's a lymphoma or something else, and if suppose sometimes chemotherapy doesn't act on the tumor, so in those situations, maybe you have to decompress the lesion. Of course, if there is an instability, you as a surgeon, fix them. Another case, patient has a 40-year-old lady presented with the symptoms of sacral hyposthesia and sacral pain. On examination, she had S2, S4 hyposthesia, probably a lesion which is from the sacrum. Clinical differential diagnosis, as I mentioned, it could be an Ewing's or a chordoma, or these are three lesions which are more peculiar to take their origin in the sacrum. So this is sacral lesion. You have a very smooth lesion which is destroying the sacrum. There is soft tissue here. All this S1, S2 is gone. You see a CT scan with a huge destruction of the sacrum. You can see that there is sacral foramina is phenomenally enlarged. So there's a huge soft tissue here. Probably we thought our radiologist said there's something wrong. It looks like some benign tumor. We have debulked the tumor from the front. We took the help of general surgeon. This turned out to be a malignant peripheral nerve sheath tumor. So what is a malignant peripheral? When do you suspect malignant peripheral nerve sheath tumor? When there is a bony destruction out of proportion to the lesion, or if you have a repeated recurrences in a previously diagnosed benign nerve sheath. We had one patient where we operated twice. It turned out to be benign schwannoma, and third recurrence, the pathologist said it is a malignant peripheral nerve sheath tumor. So if after excision, if schwannomas recur, most probably the diagnosis would be malignant peripheral nerve sheath tumor. Generally, they don't survive beyond 1 year. So last topic would be a spinal myelomas and metastasis, as far as incidence of spinal myeloma are concerned, the highest tendency to reach a spine is for the myeloma. The maximum propensity of the spinal invasion is by to the multiple myeloma. Of the 100 cases of multiple myeloma, 50% of the patients need some sort of treatment, in which 5 to 10% of the patients need some form of the surgery, either a kyphoplasty or vertebroplasty or fixation. So the usual differential diagnosis for the multiple myeloma is a tuberculosis or metastatic deposits. So initially, when the patient comes, if ESR is normal, that probably it eliminates both the myeloma as well as the tuberculosis. Or if ESR is more, the tuberculosis or myeloma, then you go for a M spike. If M spike is positive, you will diagnose it as a multiple myeloma of the spine. So this is how the patient shows in this spine. There is a destruction, multiple vertebral bodies are involved, there's soft tissue, patient has paraparesis. And then how do you work up with this patient? And sometimes these patients will present with something called vertebra plana deformity, where you can see here the vertebra is like a destroyed vertebra. So what are the differential diagnoses? As a resident, you're supposed to know, I got it from Professor Kakkal Subbaraw's slide, where you have a mnemonic of melting, metastasis, eosinophilic granuloma, lymphoma, tuberculosis, infection, necrosis, or a hemangioma. So all these things, any lesion, any tumor can present as a vertebra plana deformity. If you have the vertebra plana deformity, if you have a straightforward diagnosis, the treatment of choice is to excise this and stabilize that. So how do they reach this spine? So patient, there's multiple myeloma or metastasis that reach the spine either by direct invasion or through the epidural lymphatics. And most common sites of involvement is the dorsal spine, where the most of the vertebrae are there, cervical, followed by lumbar or sacral. Most of the myeloma are lytic in nature, and 80% of the time they involve the body, for the simple reason that the body constitutes 80% of the vertebral body weight. So instability definition, everybody should know that I tell my residents that if 3Ds, dollar, deficits and deformity, it constitutes a instability. If patient has a deformity or a deficit or a pain, that indicates a instability. So a cause could be a myeloma or a metastasis. So what is the difference between the instability created by the trauma versus neoplasm? So or traumatic instability, all of you know that is an all or none phenomena, whereas the neoplastic instability tends to grow with time. And healing is not an issue with the traumatic instability, whereas healing is very poor in neoplastic etiology. And autografts, yes, but usage of autografts is discouraged in the neoplastic instability. So surgical indications for myeloma or metastasis are simple: documented progressive neurological deficits, impending pathological fractures. If primary is not known, of course, intractable pain and deformity. These are the grossly the indications for surgery in the metastasis or myeloma. Way back, it's given in 1970s. Still, they hold good. So what are the rules of metastatic tumor? There are three basic rules as a surgeon we are supposed to know. One thing we are supposed to be very clear is that no surgery is going to prolong the life of the patient. So that is the reason, as Professor Gupta said, do least invasive and best possible. And what is your goal as a surgeon? As a surgeon, improvement of the leg function is a goal. So if you keep these 3 points in your mind, your case selection will be absolutely fine. They will not enter into complications. So how do we plan the case? First, we have to know the extent of the disease. We do a F18 bone scan of the entire spine. You know where all the lesions are. Here is the lesion one, this one, this one. So which lesion is probably producing the deficit? You are supposed to know with the bones scan. You should look at the extent of the bones, extent of disease in the spine. Be known by the CT scan alone. No other investigation will replace the CT scan. So in CT scan, you will come to know that whether how long is how bad is the vertebral body destruction, whether how much is destroyed, is it stable or unstable. And third thing is MRI. MRI is very important because you know that part of the lesion which you are supposed to remove, decompress in order to provide neurological recovery. All these three investigations are mandatory in evaluating and treating the patient for best possible outcomes. So goals of the surgery, you have to decrease, increase, and maintain. You have to decrease the pain, increase the neurology of the patient, and you're supposed to maintain the insult. There are three things which are very important as far as your surgery indications are concerned. So selection has many issues like medical fitness issues, clinical presentation issues, oncological status. Of course, the fourth important thing is whether it is accessible to you or not. The lesion is accessible to you. Can you safely remove it or not? That's a very important issue while selecting the patients for the surgery. What are the contraindications? Suppose if a patient has widespread systemic disease, say no to the surgery. And if he has a limited lifespan, less than 3 months or 4 months, there's no point in keeping him in the hospital for that period. You do some operation surgery, wounds get infected, they will put a drain. All this life which is supposed to spend with his relatives will be, in the hospital itself. Of course, the lack of ICU and severe cardiac and pulmonary compromise are another contraindications. So these patients will have a lot of issues like age, comorbidities, osteoporosis, patients already on steroids, malnutrition, low hemoglobin, and visceral involvement, liver. All these things are very important to look into those issues before you put a knife on these patients. So sometimes you may come across a lesions like this. This plus or minus unstable. This looks okay, but entire the medulla is gone. So this sort of situations, you can just take the help of kyphoplasty or vertebroplasty, because if you subject this sort of impending collapse patients to radiotherapy, radiotherapy is supposed to worsen the stability of the spine and give rise to instability following the radiotherapy. At that point of time, after radiotherapy has caused the instability, going for surgery will be little tricky. Rather, the healing issues would arise. In these sort of situations, probably you can take help of the therapeutic modalities like kyphoplasty or vertebroplasty. So metastatic lesions, primary surgery, when do you do? Surgery after radiotherapy and chemotherapy, when do you do? So primarily you do surgery when there are radio-resistant tumors, of course, when they are causing instability, of course, when there is a cord compression. Then when do you do surgery after radiotherapy and chemotherapy? So same thing, cord compression instability remains the same for both. And if there sometimes the chemotherapists will ask you to check for the residual disease. So that may very rarely we end up operating on the surgery after chemoradiotherapies. So what are the advantages of surgery in this patient? So one of the most important advantages is the ability to ambulate following the surgery. So when they have done a study, they found that with the surgical stabilization, patients could get almost 122 days versus 2 weeks without surgery. So surgery has definitely a role in this patient, but the case selection has to be very proper. So what are the other advantages of the surgery? One, you provide not only the locomotion, but also you will provide a rapid pain relief. Sometimes steroids, patients will be bombarded with the steroids for the sake of neurological recovery. They can be stopped. You can recover the bony strength immediately, and sometimes because of your debulking of the tumor, chemotherapeutic dosage can be reduced. So this is two scenarios. One is one scenario where the thyroid as a primary, where the posterior elements are involved. Patient is intact, Frankel grade E, PET doesn't show any systemic deposits. His performance score is 80 and has a sclerotic metastasis, versus that patient where there's a lung primary, anterior elements are involved, is a grade 0, PET positive, KPS 40, lytic metastasis. So which one would you like to operate? If these two patients come to me, I will go for this case because I have a leverage of thyroid primary can be treated with medication. Even after you do the surgery, patient can have a treatment for his primary, and this is reasonably controllable compared to the lung malignancy. So Frankel grade A, there's no point in operating because your goal of surgery is to maintain the low function. And of course, performance status of 40 doesn't really make any sense of operating this patient. So selecting a patient is very important in terms of knowing the primary, where are the disease, how is the neurological status, what is a PET status, what is his performance score. All these things have to be kept in mind before you put the knife on the metastatic tumors. So before I conclude, there is an entity called a total spondylectomy, which has been indicated for those patients where there is a solitary metastasis, when there is a treatable primary. So this when there is a tumor, the extent of resection should include the disc above and disc below. If you look at the posterior surface, you only have to remove the facets of the upper vertebra and lower vertebra. And the rule is to have, in any metastatic disease, 2 levels above, 2 levels below. And patient has to be, he should have a structured graft in front. So what are the indications of total spondylectomy? He or she should have a single lesion, and that has to be accessible. And patient should have fairly long survival time that you have to discuss with the chemotherapist or a radiotherapist, and of course medically fit. Of course, this particular surgery has its own set of instruments in order to do that. See, we not our routine instrument, they do not help in performing this. So they have specialized spoons where you can mobilize the paravertebral gutters to avoid the vascular damage. So in nutshell, the life more than 3 months are the surgical candidates. When there's a widespread lesions, say no to surgery. Intracompartmental lesions, basically percutaneous now techniques are more useful than the open techniques, and individualize the treatment to every patient. And you should keep it in mind that radiotherapy can induce a vertebral compression fractures. Suppose if you are in dilemma whether to fix or not, if a patient is going for radiotherapy, best thing is to fix him and then send him for the radiotherapy. So to conclude, all spine tumors are look-alike and presentation is similar, and benign lesions in the spine needs aggressive treatment, whereas malignant lesions aim for palliation. So you can't be aggressive in the malignant lesions, and you should never ever compromise on investigations to be performed. And all vascular lesions needs a preoperative embolization, because in the spines, even a slightest pressure on the cord while trying to stop the achieve hemostasis can give rise to deficits. All hematological malignancies, primarily the treatment to be given by the medical oncologist. So ultimately, your judgment depends on assessing the risk versus benefit. I thank you very much for all patient listening.
Is there any questions from the audience?